Good morning. Can you hear me okay? High five? Something? Thank you. Give it another minute or so. Low numbers today. What are we gonna do? I think I'm gonna give it another second or two. Hi, Judy. I think we all got 2 attendees today. This is not, we've had better numbers than this. Well, I think I am going to start. Yeah, I'm gonna start. Good morning, I'm Dr. Lindsay Nelson. Today I'm gonna be talking about cardiovascular disease in women. I've done this lecture numerous times talking about risk factors, signs and symptoms, getting diagnosed, treatment options, that type of stuff. And it's a very long lecture. So today I really wanted to focus on testing so we can get early detection. And that is because heart disease is the leading cause of mortality in women in the United States. In fact, 1 in 3 women will die from heart disease. 2/3 of the women who die from cardiovascular disease, though, have no previous symptoms. And over 50% of the population of women believe that they aren't at risk. So to me, that there's this real disconnect. We need to diagnose and prevent early on. We need to educate women so that they can be advocates for themselves. The blunt truth is that women are underdiagnosed, undertreated, and underrepresented in studies. And so for women and men, heart disease doesn't present itself the same way. For women, we tend to get microvascular coronary disease, meaning the small blood vessels that surround the heart, that feed the heart, we start to see damage to those arteries. And men get the obstructive type of coronary disease, meaning one of the major arteries or vessels that are coming in and out of the heart get obstructed. So men tend to explode and women tend to implode. Because there is no blockage with women, we don't see the pain, the grabbing the chest, the collapsing, that type of stuff. And yet that's what we associate with heart attacks. For women, the symptoms we start to see they can be really nebulous symptoms like jaw pain, fatigue, trouble breathing, upper abdominal pain, back pain. Ones that we would associate more with heart disease would be like the chest pressure, nausea and vomiting, maybe the clammy skin, a rapid or uneven heart rate, dizziness. Those last few symptoms that I mentioned, those might send you to the hospital. But what I worry about is the women who have maybe upper abdominal pain or back pain or jaw pain or just fatigue. How many of those women are going to be going to the hospital to get worked up? How many of those people are bringing it up with their physicians that they're experiencing fatigue, trouble breathing, that type of stuff? There are different forms of cardiovascular disease, but women are more likely to die from a heart attack or an MI and a stroke versus men. So again, it's very important to start testing women early on and looking at their overall risk factors. It's important because it's important to start testing early on because heart disease is a silent killer, right? We don't see symptoms until massive damage has already occurred. And remember that heart disease or cardiovascular disease at the end of the day is just a form of inflammation. So like with all my patients, I want to be looking at inflammation early on. Tests that I do with my patients, I'm always, every year, going to do a comprehensive metabolic panel looking at major organ function, a CBC looking at white blood cells, red blood cells, looking for anemia. That's important. Ferritin is also an important part of that kind of cardiovascular disease workup. A full thyroid panel. When I say full thyroid, that's a TSH, a free T4, a free T3, a reverse T3. These are important to get done every single year. And then to be more specific to cardiovascular disease, I'm going to do a CRP-HS. That is a inflammatory marker with a high sensitivity, looking more in the cardiovascular realm of inflammation. Women tend to get endothelial dysfunction. That is, the muscles of the arteries don't pump as well as they should. We start to see stiffness, fibrosis. When there is minor tears, the body comes and tries to repair it, and then we get altered remodeling, and then again, not being able to pump like it should. And the presence of this is characterized by increased inflammatory cytokines like interleukin-6, TNF, and decreased nitric oxide. So I really want to look at the inflammatory aspect of inflammatory aspect with women in cardiovascular disease. I also want to run a homocysteine. A homocysteine is a toxic metabolite, and it's associated with an increased risk of heart attack. Fibrinogen looks at kind of basically how sticky the blood is. That'll be increased risk for high blood pressure and clots and that type of stuff. I want to look at their blood sugar. Remember that anytime we have high blood sugar, that just feeds the flames of inflammation. So I want to do a hemoglobin A1C. I might even do an insulin depending on the patient. I want to run a UA looking at urinary albumin versus creatinine ratio. This is going to show me if there's some protein getting into the urine, which would be an increased risk for cardiovascular disease. The other thing that I think is very important is advanced lipid testing. Here's the thing about your regular lipid panel, your HDL, LDL, triglyceride, that type of stuff. Normal values are very different for women versus men, and even women who are premenopausal versus postmenopausal. The risk for cardiovascular disease in premenopausal women versus postmenopausal women is very different. For instance, total cholesterol is not really a risk factor for women for cardiovascular disease that unless it's super high, like 265, and they are premenopausal. A low HDL, remember, is your good cholesterol, is more of a risk factor for heart disease. The ratio of total cholesterol to your good cholesterol, your HDL, is more reliable. For women, their triglycerides are more of an indicator for heart disease. I want to get the advanced lipid testing will look at those LDLs, those bad cholesterols. It'll break them down into different particles, and some of them are worse for cardiovascular disease than others. Some of them will be better treated with niacin and bioidentical hormones, while others will be more like diet and fiber, that type of stuff. So it also helps me to treat patients. Lipoprotein ratios are more effective at predicting a risk for a heart attack. The other thing that I think is really important for women is to get an adrenal stress test. Stress is more of a factor for women than men. There is something called broken heart syndrome. Stress is absolutely a risk for heart disease with women, especially women under 50. Stress causes 2 times more ischemia. That's low to like no oxygen getting to those small arteries. So an adrenal stress test allows me to see what a patient's cortisol burden is like throughout a day. It's not a perfect day, but it's not a perfect test. But if I'm seeing a patient who has overall high cortisol levels, then I'm going to be concerned. Same with a patient who I see really low cortisol levels, right? Cortisol is your natural anti-inflammatory. So if they're not producing their natural, prednisone or cortisone, then we're going to see them more likely to be inflamed. And then lastly, I want to do a female hormone panel profile on most of my patients. Estrogen naturally in the body prevents arteries from hardening and becoming inflexible. And remember what I said, women are more prone to this non-obstructive heart disease, this endothelial dysfunction, right? Those arteries aren't pumping like they should. Estrogen is also anti-inflammatory, and it helps with stress. A lot of women who go through menopause will complain about mood changes, irritability, lack of sleep, that type of stuff. So it's important to get a female hormone profile as well. Stress tests are useful. Stress test is basically an EKG and someone's exercising. That's going to be important for patients that are symptomatic or maybe at a higher risk factor than other women. The nice thing about that is that if you get a negative, then we're about 98% sure that there is no ischemic heart disease. Another one that I think is important is a coronary artery calcification, which is a CT. And that it detects and evaluates calcified stable plaques in the vessels. So a lot of things that I've mentioned. I'm sure that I might have some questions later on. Please email me. A copy of this will be on my website, drlindsaysnelson.com, or email me at drlindsaysnelson@gmail.com. But at the end of the day, I just want women to realize that heart disease is a real risk factor. No matter how healthy you think you're living, it's important to just get some of this basic blood testing done every year. Ask for an advanced lipid profile, ask for a homocysteine, a fibrinogen, a thyroid panel. We need to start being advocates for ourselves so that we can change these statistics. Thank you, everyone. Does anyone have any questions? No? Maybe? Put it in the chat box if you do. Thank you. Appreciate it. Appreciate you guys showing up. We did end up getting a few more people popping in, which was nice. Again, I don't know what I'm going to talk about next week. Next week I'll be on vacation. It'll be something fun. Maybe I'll get maybe I'll drag my family into it, get them involved. All right. I guess I'm going to sign off then. Thank you everyone for attending. Hope you all stay healthy and well. And hopefully I'll see you guys next week. Bye.